Welcome to the inaugural Collaborative Group of the Americas for Inherited Gastrointestinal Cancer podcast series. This series is presented by the CGA Education Committee. This year's series will focus on the multidisciplinary, patient-centered approach to management of Lynch Syndrome. The aim of this series is to hear from experts about how they counsel their patients on cancer risk reduction strategies in Lynch Syndrome.
My name is Beth Dudley. I am a genetic counselor at the University of Pittsburgh, and I will be your host today. Before we start, I'd like to remind you that the content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health professional with any questions you may have regarding a medical condition. During today's podcast, I will be speaking with Dr. Jodi Maranchie, a urologist at the University of Pittsburgh Medical Center, about management of urologic cancer risk in individuals with Lynch syndrome. Dr. Maranchie earned her medical degree from Northwestern University. She then completed her residency at Harvard University and went on to a fellowship at the NCI with a focus on familial renal cancers. In 2006, she joined the faculty at UPMC and currently serves as an associate professor. Dr. Maranchie, thank you for speaking with us today.
Thank you for inviting me.
So I think we are all aware that there's some increased risk for urinary tract cancers in individuals who have Lynch syndrome. But I have the impression that there may be some debate about what types of urinary tract cancers are associated. How do you typically counsel patients with Lynch syndrome with respect to the types of urinary tract cancers they may be at an increased risk for?
So the classic tumor that's associated with Lynch syndrome is the upper urinary tract transitional cell carcinoma or urothelial cancer. These are tumors that arise from the lining of the urinary tract, and they can occur in the renal pelvis or in the ureter, or less commonly in the bladder. Reports have suggested that prostate cancer may also be associated with Lynch, with an increased incidence of 2 to 4-fold, and renal cell carcinomas have also been seen with an incidence of about 2% in Lynch syndrome.
And that would be a varying histology, I assume, the renal cell cancers?
All histologies have been reported.
I know that guidelines for urologic cancer surveillance in individuals with Lynch syndrome have changed over time. For example, when I started practicing, we suggested that patients consider renal ultrasound and urine cytology every 1 to 2 years, typically beginning in their 30s. Later, the guidelines changed to consideration of annual urinalysis. And the current guidelines indicate that there is insufficient evidence to recommend a particular surveillance strategy. Are you an advocate for urologic cancer surveillance in individuals with Lynch syndrome?
So the controversy arises because our screening tests have such a low sensitivity. Cytology in this setting has a sensitivity of about 35%. So you can do it annually and you may pick up some, but a negative study is not going to offer any reassurance. The cost and labor-intensive nature of that study doesn't make it suitable for a screening test. Urinalysis, however, is a simple and inexpensive screening test that identifies blood in the urine, which is probably the most sensitive finding to suggest a urothelial cancer. And among the urologic community, we typically are recommending that patients with a known history of Lynch be screened annually with a urinalysis to detect blood in the urine.
And what age would you typically suggest that begin for younger individuals with Lynch syndrome?
That should be started in the early 30s, between 30 and 35.
And do you make any sort of different recommendations based on which gene a person may have a mutation in, or whether or not a person has a family history of urinary tract cancers?
So, analogous to other familial syndromes, we used to believe that there were specific mutations that gave us a higher risk of urothelial cancer. That has not proved to be the case. And 78% of patients who have urothelial cancer with Lynch syndrome have no prior history. So there doesn't seem to be a specific point mutation. That said, we know that patients with the MSH2 mutation are at increased risk of urothelial cancer. One Dutch series looked at their families with Lynch and found that there was an overall incidence of upper urinary tract tumors of about 28%, which increased to almost 35% when they looked only at those with the MSH2.
So Dr. Maranchie, obviously urinalysis is one way that we may be able to increase early detection of urinary tract cancers. Can you tell us anything about possible symptoms that patients should be aware of to bring to the attention of their doctors?
So the number one most important thing would be blood in the urine that they can see. If they find any blood in the toilet or on their tissue, that should prompt immediate evaluation. And that's true even if that's the only time they see it and it goes away, because these tumors don't tend to bleed continuously. They will bleed intermittently, and they may only bleed once. So they should not be reassured because it's gone.
And is there anything that people can do to help reduce their risk for urologic cancers?
Stop smoking. The number one risk factor for any urothelial cancer is tobacco. And in general, people think of lung cancer as the highest risk with smoking, but the bladder is actually more sensitive to tobacco even than the lung. And we know that for patients who have one tumor, their risk of recurrence will go down if they quit smoking almost immediately, so they can have a direct impact on recurrent tumors. Aside from blood in the urine, tumors in the kidney and ureter typically cause no symptoms at all until they become very large or spread. If the tumor is arising in the bladder, patients may complain of irritative voiding symptoms, increased frequency of urination, increased urgency of urination. But again, the blood should prompt an immediate evaluation.
So Dr. Maranchie, if a person is diagnosed with a urologic cancer and they have Lynch syndrome, are there any special considerations for the treatment of that cancer that should be taken into account?
No, we treat these tumors stage for stage exactly the way we would treat a sporadically occurring urothelial cancer. The only difference is that because we know that Lynch gives them a lifelong risk of developing tumor, perhaps on the contralateral side, we will make every effort to spare the kidney and the ureter, evoking laser or retrograde ablative procedures wherever they are feasible.
And if a person with a urologic cancer does need to have chemotherapy, I assume that a person with Lynch syndrome would potentially be eligible for some type of immunotherapy, just as we would consider for a person with colon cancer or another Lynch-related cancer. Is that accurate?
Absolutely. The new checkpoint inhibitors have been a blessing in cancer for so many of our tumors, and they have definitely demonstrated efficacy with urothelial cancer.
So, especially given the fact that there are potential options for checkpoint inhibitors, I could see that we may want to make some effort to increase our detection of Lynch syndrome in individuals with urologic cancers. I'm sure you're aware that there have been a few recent studies investigating the prevalence of mismatch repair deficiency in urinary tract cancers. And the data from these studies suggests that universal screening of upper urinary tract cancers identifies mismatch repair deficiency in maybe 7 to 11% of cases. What are your thoughts about the feasibility of implementing universal screening in this setting? Do you see benefits? Do you see any limitations?
Well, that is an impressive number. That's a high incidence of occult Lynch syndrome, and I think that it would be very reasonable to screen these tumors. They're not common in the general population, especially in younger patients. And I would say any younger patient presenting with an upper urothelial tract tumor could easily have immunohistochemistry done on their tissue specimens to determine if there is an associated mismatch repair deficiency. This could not only help with their treatment, but also help to diagnose the syndrome for them and for their family members.
I think that it would potentially be another avenue of increasing our detection of Lynch syndrome, which of course has kind of cascading implications for the whole family. Alrighty, I think that's all the time we have for today. In summary, we know that individuals with Lynch syndrome are at an increased risk for urologic cancers, primarily transitional cell or urothelial tumors in the upper urinary tract. Urinalysis could be considered as a screening tool for these cancers, and individuals with Lynch syndrome should definitely avoid smoking as a means to reduce their urinary tract cancer risk, and be attuned to blood in their urine as a symptom to bring to their doctor's attention. If an individual with Lynch syndrome is diagnosed with a urinary tract cancer, they may benefit from immunotherapy. Dr. Maranchie, thank you for sharing your expertise with us today.
My pleasure. Thank you, Beth.
Please stay tuned for our next podcast featuring Dr. Nadine Tung, a breast medical oncologist at Beth Israel Deaconess Medical Center. She will be discussing what we know about the risk of breast cancer in Lynch syndrome. Please follow us on Twitter at CGA-IGC. If you value this type of educational content, please do consider becoming a member of the Collaborative Group of the Americas on Inherited GI Cancer Syndromes. You can get details from our website at www.cgaicc.com.